Very good afternoon and a warm welcome to all the doctors who have joined us today in a busy afternoon for yet another session in the series of NEFFRON, which is an educational initiative by Saffron Formulations that involves the expert in the field of nephrology to share their expertise and clinical experience in the field of nephrology and how to deal with different aspects of kidney disorders. So, to start with, let us first introduce our clinical expert for the day, Dr. Himanshu Sharma. Dr. Himanshu Sharma has been associated with Gandhi Medical College, Bhopal, as an associated professor of nephrology. He has done his DM nephrology from AIMS, New Delhi, and has over 17 years of medical teaching experience. He has done his MBBS and MD from GMC Bhopal. Sir has a wide affinity towards patient engagement as well as teaching different faculty members as well. So, with this, I would like to welcome Dr. Himanshu Sharma to guide the audience on a very important topic that is hyperuricemia, what, when, and how to address.
Good afternoon, all. So today we are talking about the hyperuricemia, which is a very commonly encountered thing in a general day-to-day practice by nephrologists as well as general physicians. So I'm sharing my screen. Okay. Oh, so now today we are talking on the topic of hyperuricemia. Basically, what is hyperuricemia? It is a elevated level of serum uric acid caused by either deficiency of uricase enzyme or a lower urinary uric acid excretion, resulting in the crystallization of uric acid into urate. And as this level of uric acid is increases, in men, it is more than 7, and in female, it is more than 6 milligram per deciliter is considered as hyperuricemic. Talking about the symptoms of hyperuricemia, basically the symptoms which appears in a hyperuricemia are especially joint pain, redness, tenderness of the involved joint, and most commonly the involved joint is the lower limb involvement with first metatarsal joint. So this is the symptomatic hyperuricemia, also known as a gout. And in this condition, the monosodium urate crystals are usually got deposited in joint synovial fluid, and the patient becomes symptomatic with the joint pain and swelling. So this is the symptomatic hyperuricemia termed as gout. But majority of the patient, nearly two-thirds of the patient with hyperuricemia are nearly asymptomatic. So today we are talking about hyperuricemia, asymptomatic hyperuricemia, especially in concern with the chronic kidney disease or kidney dysfunction. There are a good number of studies across literature available, which shows that there is a relationship between the increased uric acid levels and the progression in the chronic kidney disease or appearance of a new onset kidney disease, especially if the uric acid levels are on the higher side. So there are the various mechanisms described by which a hyperuricemia can contribute towards the chronic kidney disease and the progression of the kidney disease. Especially this uric acid causes endothelial dysfunction, increase the inflammation, oxidative stress, also stimulating the renin-angiotensin system, leading to the increased vascular resistance in a renal vasculature, causing a reduction in the GFR. Also, this uric acid, because of increasing the inflammation, they increases the tubulointerstitial inflammation and promotes the fibrosis, which in turn increases the chronic kidney disease and progress and help in the progression of the chronic kidney disease. So there are other factors which lead to hyperuricemia in CKD. So they are goes hand in hand, the uricemia, hyperuricemia, and the chronic kidney disease. In chronic kidney disease, the uric acid levels are also increased because of reduced GFR. Use of diuretic in many of the kidney disease CKD patients are on diuretics because of poor GFR and reduced urine output. So the use of GFR, use of diuretics, reduced GFR, increased vascular resistance, and coexisting insulin resistance. These all together lead to hyperuricemia in a CKD patient. So then what how you are going to diagnose a hyperuricemia? The most commonly used parameter is the uric acid levels in the serum uric acid levels, which are most commonly available parameter to us. And along with that, if the patient is symptomatic with the joint pains, some of our orthopedic colleagues, they used to get an synovial fluid assessment for urate crystals. Okay, but the normal presentation is usually a joint pain, monoarthritis, lasting for around 1 to 2 weeks, followed by a symptomatic period of varied duration. In a later conditions, these chronic inflammation, repeated episodes of pain and inflammation leads to the joint involvement, and in a longer run, there may be a joint deformity in these type of patients. This is about the patient those who are symptomatic. But what about the patient those who are not symptomatic or asymptomatic patients? So these asymptomatic patients sometimes, if they have a renal involvement and they have a poor renal function, these patient asymptomatic patient may develop a progression of renal dysfunction in longer case. This is how the gout and hyperuricemia is diagnosed as a gold standard by identification of monosodium urate crystals in the synovial fluid. Now, when you have diagnosed a patient with the hyperuricemia, then question arises how when to treat. If the patient is symptomatic, you need to treat the patient. But the question arises, what about the asymptomatic patients? Whether you have to treat them or not. So in these conditions, if the patient is asymptomatic with the hyperuricemia, there are very specific conditions where you need to treat the patient. Otherwise, you have to keep the observation, dietary modification, so that to keep the uric acid under control and observation of the patient to assess the progression of the disease. Such as in a chronic kidney disease, if the patient is having a progressive kidney disease, in that condition, you may require to treat the patient to lower down the uric acid to reduce the progression in a CKD patient. There are a good number of studies which shows that the increased in uric acid level causes the chances of doubling of CKD in a longer duration. So there are various other studies available which shows that in a chronic kidney disease patient, because of increased level of uric acid, there are chances that they may progress rapidly to the ESRD state. These are the few studies available which shows that elevated uric acid levels was an independent risk factor for the end stage renal disease. Also, there is these are independent risk factors for progression to dialysis in a ESRD patients. So, but overall, now that asymptomatic treatment of asymptomatic patients are usually not recommended but there are few of the studies available, even from our country as well as from outside, which shows these are the randomized controlled trials conducted in the patient of CKD itself. That lowering of uric acid level helps in reducing the progression of the CKD in various groups of the study groups. So there is one of the this diagram showing when to treat in a CKD patient. If the patient is a CKD with hyperuricemia, if the patient is symptomatic like gout, urolithiasis, you need a treatment. You need to treat the patient with the uric acid lowering drugs. If the patient is asymptomatic, then usually treatment is not required. But in a CKD patient, if the patient is having a progression in the chronic kidney disease, there is a decline in the GFR, then in that condition, in the case of worsening of the GFR, you need to treat the patient. And if the patient is not having a CKD, then you have to treat only if the patient is having gout, joint pain, or urolithiasis. Otherwise, in other conditions, you have to observe the patient and monitor the patient. Now, coming to the treatment part, what are the treatment for the hyperuricemia, the symptomatic or special condition with asymptomatic one? These are the uric acid lowering agents. Xanthine oxidase inhibitor. This group of drugs are used as a first-line treatment in all of the guidelines. The two most common drugs which are commonly used by physicians and nephrologists and orthopedic surgeons and across the world are allopurinol and febuxostat. With comparing these two drugs, allopurinol is an older one. It basically reduces the serum and uric acid level within the 24 hours and with the maximum effect by 2 weeks. Usually, dose is 300 to 400 milligram in daily dosing. In a renal insufficiency, we need to reduce the dose of allopurinol because of its metabolite, which is accumulated in the body. Major of the side effects seen with the allopurinol are skin rashes, hepatotoxicity. One of the severe side effect is a SJ syndrome, and whereas in the febuxostat, it reduces the serum and uric acid level within 24 hours, and the maximum effect is also attained up to the 2 weeks of time, where the dosage is around 40 to 80 milligram per day, and the dose does not need to be adjusted in mild to moderate of renal failure. Whereas the common adverse effects seen with these drugs is nausea, hypersensitivity, deranged LFT, in a severe cases, the drug itself can cause tubular interstitial nephritis in very rare conditions. Talking about the febuxostat, which is a novel and very potent uric acid lowering drug, it is primarily metabolized in the liver. Febuxostat show better uric acid reduction as compared to allopurinol in various of the studies and trials things. And in many of the trials, the febuxostat comes out to be non-inferior to allopurinol in most of the trials. The one and most important factor with the use of febuxostat is its cardiovascular safety. In past, there are few trials which shows a moderately higher rate of cardiovascular event with febuxostat than allopurinol. This is one of the biggest trial which is there, which is CARES trial conducted due to FDA mandate, whether the febuxostat was non-inferior to allopurinol in a major cardiovascular events. In this trial, it was a 32 months follow-up, a median of 32 months. The febuxostat was found to be non-inferior to allopurinol in regarding to the composite endpoints of cardiovascular death, non-fatal mortality, IMI, non-fatal stroke, unstable angina, or urgent revascularization. But when the endpoints are primary endpoints are analyzed in the secondary data, the febuxostat appears to be having a higher rate of cardiovascular death than the erlopirenol. That's why it is labeled as a causing a higher all-cause mortality, and because of that, the use of febuxostat was labeled with a very high cautious because of these outcomes in this study. But in comparison to this study, case study, another study was done, which was a fast trial, which was conducted for the long-term cardiovascular safety for the febuxostat as compared to the allopurinol. And this long-term cardiovascular safety trial, the it was found out that febuxostat is non-inferior to allopurinol therapy respect to the primary cardiovascular endpoint, and this long-term is not associated with increased risk of death or serious adverse event compared with the allopurinol. So, in present scenario, there is a still in view of these two trials, there is a lot of dilemma in uh, treating physicians and all. So, but we can use these drugs with a very caution and as per the need of the our patients. So, although there were concern regarding the cardiovascular safety of the febuxostat in early clinical trials, it is now established that the clinical trials with febuxostat initiation was not associated with higher cardiovascular risk factors, including cardiovascular or all-cause mortality compared with erlopirinol. But we should be remain very cautious in our use of a particular drug. So with this, I want to summarize on this thing that this allopurinol and febuxostat both are very good drugs for the use in hyperuricemia. But still, the use of febuxostat is also is improving nowadays in the presence of the newer studies, which shows there is a no such increase cardiovascular mortality in the patients with the use of febuxostat on a longer run. Thank you.
Thank you so much, sir. So there are a few of the questions that has been come before the presentation itself. We had received few questions from the physicians. One of the questions being that whenever there is asymptomatic hyperuricemia, there is always a dilemma. So what is the cutoff value that you think, sir, has to be treated irrespective whether there are no symptoms or there are symptoms arising in the patients?
See, as such, there is, as per guideline, there is no such thing whether you have to treat asymptomatic uricemia. It is more advisable to keep an eye on the patient with the asymptomatic one. But if the patient is of high risk, like diabetics, like cardiac patients, and is having a higher uric acid level, especially above 9 milligram in a male and 8 milligram in a female, is usually is on safer side. You can start using uric acid lowering drugs to reduce the uric acid level within a normal range, so that the adverse effect of the uric acid is prevented.
Sir, regarding the patients who are going through the chronic kidney disease, what is the duration that you suggest for the uric acid treatment? Because they also have a lifelong therapy and there are multiple medications being given to the patients.
Right.
And there is also a risk benefit that has to be catered to. So, is there any particular duration that you see in such patients?
Especially, very good question, because especially in a CKD patient, because of the renal hemodynamics, as I explained in one of the slides, that because of the reduction in the GFR because of CKD, the excretion of the uric acid is reduced, and it leads to the hyperuricemic condition. Most of the time it is asymptomatic, but with the due course of time, it becomes patient may become symptomatic, or that increased uric acid may start damaging the kidney itself. So in that condition, we usually do what we start the hyperuricemia treatment for a short duration, not for a lifelong. Short duration of the therapy, reduce the uric acid within normal range, and also along with that, the most important thing is the dietary advice. So you have to reduce the dietary intake for protein, so that the formation of uric acid will be reduced. So this is what we usually recommend in a CKD patient. That's why the most of the CKD patients are advised to have a low protein diets. So that is mandatory because of the CKD per se. So that will help in the reducing the production of uric acid in this particular group of patients. And for a short duration, you use the drugs, and then once the patient is asymptomatic, drug in within the levels are within normal range, you can take off the drug from their medications because there are lots of drugs are going on.
Correct, sir. So, like when patients is already having diuretics, like how do you manage the hyperuricemia treatment and the side effects of diuretics on the patients, especially the patients who are going through dialysis?
See, the dialysis patient and the important thing with dialysis patient is when the initial condition of the dialysis, the when patient requires a higher diuretic level, diuretic doses to maintain a urine output. In that time, it's a little bit of difficult. But in later on, when patient become anuric, most of the time we withdraw the diuretics and patient will remain on dialysis for the volume control in the body.
So regarding the strength and the dosage of Ebixostat, like when you start the therapy, you usually recommend a higher dose in progressive kidney disease, or is it like you start with a lower dose and then up titrate the dose?
See, in a early to mild to moderate thing, there is no dose reduction modification in febuxostat. So we can use a normal dose in the in early stages, but as the disease progresses, we have to reduce the dose to so that the side effect of drug can be prevented.
So since a lot of physicians are watching this live on YouTube, there one suggestion regarding the patients who are into different comorbidities, be it renal impairment and diabetes. So, like, there is always a dilemma when the guideline is suggesting for the Indian patient and with respect to the international guidelines. So, how can we bring both of this together and create a consensus that okay, this is how we are going to treat hyperuricemia? So, what should be the ideal approach of treating the patient?
See, in our patients, in a multi patient with the multiple comorbidities, the use of drugs should be very cautious. If the use of drugs should be done only when it is absolutely indicated. Other methods like non-pharmacological method, dietary modification, they should be also started along with the drugs if required. Because the drugs alone can't help because we can't keep on giving drugs lifelong to the patient. So the dietary modification, lifestyle modification, these are also very much required, especially in a patient with comorbidities, because they have already on multiple drugs. So in this group of patients, definitely the non-pharmacological methods along with dietary modification and other things also help in controlling the uric acid levels in most of the patients.
Thank you so much, sir. With this, we come to an end of the session. And for the knowledge of the people who are watching today, this session we'll have the recorded version available on YouTube and you can watch it as per your convenience at any given point in time. And you can share your comments, your thoughts, or any questions with regard to the presentation. And you can ask Dr. Himanshu Sharma also for his clinical expertise. So with this, I would like to propose a vote of thanks to Dr. Himanshu Sharma for, despite his busy schedule, he spared his time and shared his clinical experience and thoughts regarding hyperuricemia. Thank you so much, sir, for joining in and giving a very comprehensive and a crisp presentation. And we'll share the session link to you as well, sir, which you can circulate with your colleagues as well as with your faculty members as well. Thank
Thank
you
you.
so much, sir.
Thank you, Anjali, for providing me this opportunity to express my opinion regarding this on this topic. Thank you very much.
Thanks a lot.